So, good morning, good evening, and good night from everyone across the globe that's joining us for this edition of the EIOC Journal Club, specifically known as Onco Discussions. Today, we're going to be talking about second line therapy in patients who have hormone receptor positive, HER2 negative metastatic breast cancer. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very bright, very hot and warm, and very safe United Arab Emirates. And I'm joined by spectacular faculty from Bahrain, who are all my friends, and I hope I'm their friend as well. And Peter Fasching, who comes to us all the way, he tells me from a very hot day in Germany. So, Peter, would you like to introduce yourself? You're muted.
Yes, I'm Peter Fasching, and I'm a women's cancer specialist in the Comprehensive Cancer Center in Erlangen. It's a small city, which is also one of the hospitals of the National Tumor Center Network. So it's a quite big comprehensive cancer center. Thanks for having me. I hope some of you are my friends too. I hope so.
Ahmed, would you like to introduce yourself? You're muted. You're muted, Ahmed.
Good evening, everyone. I'm Dr. Ahmed Ali Obaya, consultant medical oncology, Bahrain Oncology Center. It's very hot in Bahrain also, يعني Peter.
But we have air conditioning. Peter doesn't have air conditioning. Maha.
Good evening, everybody. Thank you again, Dr. Salah, for your invitation. I'm very happy to be with you today. My name is Maha, I'm a medical oncology consultant in Oncology Center.
So, Maha, just to let you know that the voice from your end is sounding a bit muffled.
Really?
Yeah, so maybe you can,
I'm
reconnect.
I'm fiddling around with my connection.
And then Ozge.
Yes, good evening, everyone. This is Ozge Keskin, consultant medical oncologist from Bahrain Oncology Center. Thanks for the great meeting again. I believe it will be as great as the last time.
Thank you. Sinem. Is she?
Hello.
Yes, it's
Hi.
here.
This is Dr. Sinem Akbas, Bahrain Oncology Center medical oncology consultant. As usual, I believe we will have a great meeting.
Tarkan, Dr. Tarkan.
So thank you so much for the invitation. I'm Dr. Tarkan Yetisyigit from Bahrain Oncology Center. Yesterday I had 39-degree fever, but now, alhamdulillah, I'm much more better.
I'm sorry, you had 39-degree temperature fever, but if you come to Dubai, it's 50 degrees outside. So I think you'd be playing match with the weather. So like I said, today's onco discussion is going to focus on the management of patients in that second line post-CDK4/6 inhibitor progression, really looking at that alteration, the AKT pathway, but we'll also put in some elements of other pathway be addressed, because now we know that patients with hormone receptor positive, HER2 negative MBCs, not a homogeneous disease, truly a heterogeneous one, becoming just as complex in terms of treatment, like our poster child in terms of lung cancer, where where invented. These are my disclosures. Would like to get in touch with me offline, I'd highly recommend that you scan the QR code. So first, what are the key components that influences a patient's journey who has hormone receptor positive, HER2 negative? Those patients with recurrent disease, it truly depends when the recurrence is. An early recurrence, these patients have primary endocrine resistance. If it's a few years later while they're getting their adjuvant endocrine therapy, it's a secondary type of resistance. But if it's way out after completing their adjuvant endocrine therapy, these patients still have endocrine sensitive disease. And we know those patients with stage 4 de novo disease actually have endocrine sensitive disease. Now we know at each time point, the disease tends to evolve from endocrine sensitive to endocrine resistant to truly endocrine refractory. And we know biology changes and targets emerge. But I'd like to actually ask Peter a question over here. We know this to be a fact, that with each progression of disease in patients with HR positive, hormone receptor positive, HER2 negative metastatic breast cancer, biology changes, new targets may emerge, yet there is been such a huge resistance in terms of when to actually test for those new targets. Should we do it at first line progression? Should we do it at second line progression? Should we do it at each line of progression? What are your thoughts here?
Well, clinically, as a physician, the answer is super simple, is whenever it makes sense and the therapy is suitable for the patient where we need the respective positive mutation testing. From a scientific standpoint, I think it's fascinating, but at the same time frustrating, that we just learned over the last 12 months, 24 months, for one mutation, when they start to occur as part of a resistance mechanisms, which are ESR1 mutations. PI3 kinase mutations are present from the beginning of the disease. There's not much changing of the frequency of PI3 kinase mutations, maybe a little bit, but there's only one that we have been observing is ESR1 mutations, which might have a 5% mutation rate at the beginning of the first line therapy and then go up to 40%, maybe 50% at the beginning of second line. So, Shaheenah, we actually do not know much about this scientifically, but clinically, every time it would make sense with regard to therapy, let it be SERDs, let it be olaparib, talazoparib, let it be capivasertib or other treatments that are a little bit less frequent with regard to the mutations.
So, Ahmed, in your clinic, when do you actually test for these biomarkers? Ahmed?
Actually, Dr. Shaheenah,
Yes.
you know that the first line setting CDK4/6 inhibitor and AI is a broad spectrum and no need for molecular profiling of the disease. So in my clinic, actually, on progression on the first line setting, I will do that for a patient still candidate to receive endocrine treatment, those who received clinical benefit from CDK4/6 inhibitor for more than 6 months.
Okay. Just to give you an example, I tend to honestly do liquid biopsies quite frequently for my patients because these patients are living such a long time now with all the explosion of new therapeutic agents they have. And I recently had a patient and would love to know your input over here on her 9th line of therapy. Now, when she progressed after the 8th line, I did a liquid biopsy at that point in time. And again, she's received everything under the sun. And I have all her previous liquid biopsies. The newest liquid biopsy showed a TMB of 52 and an acquired somatic BRCA mutation. And I thought that was actually quite fascinating for me. And I have actually given her a combination of immunotherapy plus a PARP inhibitor. And this is her like 9th line of treatment. And she's actually responding to treatment. And this for me was a learning point that, like Peter said, scientifically, these diseases evolve. New markers actually evolve over time. And this lady's TMB to start off with was 5. It's now 52, making it a more genomically unstable disease. What are your thoughts here, Peter?
This was several questions in one.
Good, right?
What do you mean? I mean,
what are your thoughts? Is it a good idea to actually, as your patients live longer, to actually test for those acquired biomarkers as an example of what I've just given?
Well, I mean, it depends on the healthcare system. I think in Germany, we slowly get there that the ctDNA testing becomes broadly available as far as it goes for practicability and as far as it goes for costs. So I would support you. What you just said is that you should or could test as frequently as possible. Obviously, with every therapy line. For scientific curiosity, to see is there any new mutations that come up, but also for the respective therapy. So I would completely support to doing ctDNA testing as frequently as possible.
So we know that patients experience a disease progression post CDK4/6 inhibitor with a 52% probability of actually progressing to second-line therapy within 2 years of actually commencing that first-line therapy. So you should have your plan B ready in case plan A does not work. And we know that there's a spectrum of different biomarkers that we need to be testing for in addition to ESR1 mutation, making sure that the patient's tumor is still ER/PR positive, HER2 negative, looking at those defects in the DNA repair pathway, and of course those alterations in the AKT pathway, and do not forget those agnostic markers. So Maha, I'm going to ask you the same question I asked. Oh, Maha, there's just too much noise in the background from where you're.
Okay, maybe no.
It sounds like you're having a party there.
No, not having much. This is the quietest place I could find.
Okay.
I
I
just
just
had
want to
to
know
be.
when do you okay.
Sure.
When do you
Let me try.
comprehensively profile the tumors of your patients? You're muted. You're muted, Maha.
At the moment, as you're aware, we are a public health system. So as much as we would love to do it at every progression, so we do certain things. We do somatic, for example, we do hereditary testing in the upfront for patients. Any patient who's diagnosed with breast cancer, we do hereditary gene testing for mutations. And then upon first progression, I agree with my colleague. So I would do it upon a progression, and then when you exhaust, I think the standard of care lines. So because now we have the oral surge, we have PIK3CA. So although albeit surge, or ESR1 mutation is a required mutation, so if I don't find it, I would keep on testing for it. PIK3, so we do it as well as part of the NGS biopsy, so we do it as liquid biopsy. We also sometimes, if we have fresh tissue, we can ask for it on tissue testing. And when we exhaust all lines of therapy and if the patient is still fit, we still repeat the NGS testing.
So in our patients, maybe you can mute yourself, Maha. Yes. So in our patients with hormone receptor positive, HER2 negative disease, we tend to start with first line CDK4/6 inhibitor combination endocrine therapy. We run through all the lines of endocrine therapy, either biomarker driven or non-biomarker driven, before we reach systemic chemotherapy. And really the question is, how do you determine optimal sequencing of endocrine therapy in these patients? Well, we do have some data that tells us you could potentially give a CDK4/6 inhibitor beyond progression of disease. That comes from the post-MONARCH trial, a phase 3 clinical trial that randomized patients to either use fulvestrant or fulvestrant plus abemaciclib post-CDK4/6 inhibition. And you can see it did reach its primary endpoint of improved PFS, but that benefit was modest at best. And it was mainly restricted to those patients who had endocrine sensitive disease. So, Dr. Tarkan, when do you consider giving a CDK4/6 inhibitor beyond progression of disease?
I have currently 2 patients who slowly progressed on CDK4 and had a long PFS with palbociclib. I switched them to Abema and they are doing well.
Okay.
Yeah,
And
low volume disease, slow growing disease. And if the patient already used palbo, I'm easy to switch to Abema. And tolerating the treatment well, yeah.
perfect. Peter, when do you consider giving CDK4/6 inhibitor beyond progression of disease, or do you think this is not a strategy we should be doing? Because a lot of the data now, especially with the use of oral SERDs, is now combining CDK4/6 in that second line setting.
Yeah, I cannot wait for the imlunestrant to be available and to combine it, after CDK4/6 inhibitor progression, because regardless of ESR1 mutation, we get quite reasonable therapy duration responses. And we should make no mistake, almost every patient in this setting will still die of the disease. So to give them a maximum time of a good quality of life is of utmost important. I'm not I'm not so concerned about the duration of response as long as the patients can be kept on an endocrine treatment, and giving a CDK4/6 inhibitor first line and then giving a combination therapy that's well tolerable second line is the way to go. So giving CDK4/6 after CDK4/6 once the SERDs become available in that setting is absolute an option. And then, of course, there's new therapy options that are coming our ways, like combination with everolimus and SERDs, although I'm not so fond of the side effects of the everolimus compared to the CDK4/6 inhibitors. So I think CDK4/6 after CDK4/6, if combined with an effective SERD, is the way to go if it's available.
So now let's look at the Capitello 291 study that actually looked at patients who were in their second and beyond line therapies or after endocrine therapy. So they had to have received less than 2 lines of prior endocrine therapy. And they could have received at least 1 line of chemotherapy, randomized to get either capi plus fulvestrant versus placebo plus fulvestrant. PFS was the primary endpoint of the study, both in the overall population and in the AKT altered population. And you can see, in terms of the overall population, there was a benefit in terms of PFS of 3.6 months. And in the AKT altered population, it was a 4.2-month benefit in terms of PFS using combination of capi plus fulvestrant. When you look at those patients, in terms of the type of alteration that they had, it didn't matter whether they had a PIK3CA alone alteration or a PTEN only alteration or an AKT alteration by itself. There was a benefit to using combination endocrine therapy with capi plus fulvestrant versus fulvestrant alone. An interesting subgroup analysis was actually conducted and presented, I believe, last year, that looked at those patients who were both chemo naive, because remember, there was a subgroup of patients who had received 1 line of chemotherapy. And you can see in those chemo naive patients, they really had an excellent benefit in terms of PFS. The PFS improved from 3.5 months to 7.4 months. And remember, these are patients with alteration of the AKT pathway. And then when you looked at those patients, first line endocrine therapy. So here you've got the PFS. Now, yes, the numbers are small. You can see the numbers are about 20 patients in each arm that was getting capi plus fulvestrant in that first line. You can see the PFS actually improved from 3.7 months to 14.3 months. And just to let you guys know, you actually do have approval of using this combination as your first line therapy in terms of that first line endocrine therapy group of patients. When you're looking at, I won't show you the overall survival because it's not showing very clearly on the slide, there was still no statistically significant improvement in the overall survival of patients. But you can see that in the AKT altered population and in the overall population, there seemed to be a trend towards improvement in the overall survival. When you're looking at, sorry, my slides are not going forward. When you're looking at the subsequent treatments, you can see that in those patients who are getting subsequent therapy, you can see that these patients are getting chemotherapy, other types of endocrine therapy, even patients are getting CDK4/6 inhibitors. So again, these patients do go on to get other types of targeted therapies or chemotherapy. When you looked at the pre-specified exploratory endpoint of overall survival in patients who had received prior CDK4/6 inhibitor, again, in that AKT altered population, you are seeing an improvement in the overall survival from 21.2 months to 28.1 months. It is not statistically significant. You can see the hazard ratio crossing 1, but that is quite a good separation of the Kaplan-Meier curves in my opinion. When you're looking at the tumor response, you can see that in that AKT altered population, it's about 28.8% in terms of objective response and 9.7% in that fulvestrant placebo group of patients. When you're looking at PFS2, you can see in the overall population and in the AKT altered population, it was improved if you gave capi plus fulvestrant. And again, giving capi plus fulvestrant improved the time to first subsequent therapy. Now, when you look at that real world data, and I really like this real world data set that's actually looking at about 400 patients who had received capi plus endocrine therapy in the form of fulvestrant at various lines of therapy. You can see first line therapy, so about 6.2% of patients first line therapy are getting capi plus fulvestrant in the community, but most patients are getting it in the second and third line therapy. And you can see that the earlier you give capi plus fulvestrant, the better the prognostic outcome of your patients. Now, I would like to ask Ozge here in terms of using, first of all, testing for PIK3CA or an AKT alteration. Do you do it at the time of progression of disease or do you do it up front? Because these patients, usually 40% of patients will have a PIK3CA mutation and they will stay the same at the time of progression. So what are your thoughts here? When do you test for an alteration in the AKT pathway?
Yes, as you told, PIK3 kinase mutation, it will not change. So there is no harm to do it from before. But of course, the other, I mean, including ESR, upon progression, you can do, and even after every progression, you can just repeat it by liquid biopsy.
But when do you do it?
For actually, when practically doing in the clinic, just within the first progression, do everything. Like within the second and the third, if you have the logistics, just you can repeat everything rather than PIK3 kinase.
Dr. Sinem, when do you use when do you actually target the AKT pathway in your clinic? What type of patient would you consider giving capi plus fulvestrant to?
Actually, after the first progression, as second-line treatment, like Dr. Ozge, I'm doing the test, not in the beginning. And if I found an AKT pathway mutation, then I will go with the capi plus fulvestrant as second line mostly.
So, Peter, I showed you the real world data that actually showed that about 6.2% of patients in the community are getting it as a first line therapy. And you also had patients enrolled within Capitello that had received it as first line. That's where you're getting the biggest bang for your buck. So, in terms of using Capi plus fulvestrant, what type of patient would you consider giving it as first line?
Well, I mean, patients should not be eligible for a standard CDK4/6 inhibitor treatment. I mean, every patient where we think the CDK4/6 inhibitor is well tolerable, it's a standard treatment, it's very efficacious, we shouldn't think about it. But then, if you're having patients, you know, who have a reason for endocrine resistance, where we are suspicious that this might be due to a problem with the PI3 kinase pathway, I mean, these, according to the patients in Capitello, might be treated first line with a ACT1 inhibitor with the capivasertib. But it's a small patient population. I don't think you have to turn your clinics upside down to identify those patients. Most of these patients might benefit also after a CDK4/6 inhibitor. And we shouldn't forget patients who are hormone receptor positive, HER2 negative, it might be a little bit different from the HER2 positives and triple negatives. Almost all of these patients will ultimately die of the disease. So we have to have a good strategy how to keep them, you know, in the therapy sequences as long as possible on the endocrine treatments. And you know, there's no evidence that makes a big difference whether we give CDK4/6 first and then the ACT1 inhibitor capivasertib or the other way around. So I wouldn't be too concerned, you know, but if I am very suspicious that there might be a reason for endocrine resistance that's due to a PI3 kinase mutation or ACT or the pathway is altered, these might be the patients. But otherwise, I wouldn't be too concerned about that situation.
I think, at least for me, I think there'll be more of a role of using it in that first line setting in those patients who've used adjuvant CDK4/6 inhibitors and who've recurred quite quickly,
Yeah.
where you wouldn't really think about re-challenging the CDK4/6 and who don't really fit in AVO because, you know, they've actually received adjuvant CDK4/6. I think those patients, if they've got an alteration in the AKT pathway, my inclination would be to give Capi plus fulvestrant. Would you agree with that, everyone? This is for everyone.
No,
Yeah.
I agree absolutely. I was planning to say that things we will have in the future more use in this setting. Yeah.
Yeah. In my head, I already stored these patients as like second line, like to, you know, it's like if I have these patients that, and they come to the clinics now more and more who get a recurrence under a CDK4/6 inhibitor, they naturally are fitting the criteria of the usual second line setting that we've been seeing before the adjuvant introduction of the CDK4/6 inhibitors. And there's no other choice, you know, to treat them that way.
So I found this data that was presented at San Antonio last year super interesting because when we tend to test for ESR1, we tend to think use liquid biopsy. Sorry. But when we tend to think about testing for PIK3CA, sorry, we tend to think about doing tissue. And what essentially was shown at San Antonio last year was you had about 10.3% of patients where they looked at, I mean, this was a cohort of patients, 10.3% of these patients had detection of an alteration in the PIK3CA pathway or the AKT altered pathway that was detected only in ctDNA, raising the question, and you can see that irrespective of whether you detected it by ctDNA or by tissue, the outcome was exactly the same. So again, it didn't really matter tissue or ctDNA. Now, my question to Dr. Tarkan is, if your patient is tested with tissue and a PIK3CA mutation or an alteration in the AKT pathway is not detected, would you then go on to do a liquid biopsy, or should you be doing it simultaneously just in case? Because 10.3% is, for me, a big percentage.
Yeah, I did it, and one of my patients came positive, and she benefited amazing from the treatment.
So it was negative on tissue, but positive on liquid?
Yeah, yes. I did it as case presentation also.
Oh,
we used alpelisib, yeah, and she had almost complete response. And it was complete response. And in the study, when you see, there was only one case complete response, and that was in my practice, the first case, and she did very well.
So, Peter, when you saw this data, did it change your clinical practice to say, okay, let's test everyone dual tissue and liquid at the same time?
Well, in Germany, it's a resource problem, so it would be like one after the other. If you don't detect one in one, it's like you look in the other. But no, it didn't change drastically. How we do it. It would do the liquid biopsy first, and then go for the tumor tissue if there is a suspicion that we would find something else.
Dr. Sinem, what do you do in your clinic? Do you do dual tissue and liquid, or do you first do tissue then liquid, or liquid then tissue?
Actually, I'm doing liquid only, but in some circumstances, I am doing also from archive tissue. But generally only liquid, both for ESR1 and PI3 kinase at the same time.
So, Dr. Ozge, if you have a patient that you've done liquid and you find both an ESR1 mutation and a PIK3CA mutation, what makes you choose which pathway to target?
Good question.
I know. I'm going to ask Maha the same question next. Because she's thinking. I gave her time to think. I didn't give you time to think. So tell me how you're going to target and what you're going to target.
The first pop-up in my mind, I would go to target with first ESR1. I think so.
Why? Why would you do ESR1? I'm not going to let it go. I'm going to pick on you now. Why ESR1?
I think it is logical.
Because we have the Elevate study. Now I'm shifting the gear.
I think
In
I think
ASCO, we had a poster abstract. Tamam.
Oh.
All right. Okay.
think
I'm going to let Dr. Ozge actually think about this because I'm going to come back to you. But let me present some of the data for ESR1 mutation. We have data from Emerald. We have data from Serena 2 that tells us in the presence of an ESR1 mutation, single agent monotherapy oral SERD actually works better than using a non-oral SERD agent. However, the benefit is actually modest. We also have data from Serena 2 that tells us if you have multiple ESR1 mutations, the PFS is actually decreased. So the earlier you use your oral SERD, the better it is, so that you have one ESR1 mutation, because that's where you get, again, the biggest bang for your buck. You can see 12.9 months versus 4.7 months if you have more than one ESR1 mutation. So I'm just going to go back. I'm not going to ask you all of these questions, but Peter, I think one of the questions, and that's why Tarkan has actually brought this question up of Elevate. My question to you is, we've seen data from Elevate, which tells us you can use combination endocrine therapy with an oral SERD with either everolimus or a CDK4/6 inhibitor, and you get good efficacy irrespective of the type of biomarker that's present. Then we saw the results of the AMBER trial, AMBER 3 trial, which also told us you use imlunestrant plus abemaciclib. It works irrespective of the presence or absence of an ESR1 mutation or a PIK3CA mutation. So my question to you is, do we even need to test for biomarkers?
Um, it's a good question. I think in the second line, if a combination of a SERD and a CDK4/6 inhibitor is available, testing might not be as important because both patient populations can be put on the respective treatment. However, in order to start to plan for the respective therapy sequences, I think knowing the PI3 kinase, AKT kinase, and PTEN mutation is quite important, because you need to know what is my portfolio of therapy sequences that I can do to make the respective decisions, because otherwise you might be forced to think, of a ADC, you might be forced to think of chemotherapy early on. You just need to be informed, what are my options here, what can I do? If there's a PI3 kinase mutation, I'm not too shy to go for the capivasertib in combination with the fulvestrant, because we do know even if fulvestrant is not as effective as the SERDs, there's a good efficacy in patients with ESR1 mutation. We've seen that in several trials comparing them with the aromatase inhibitor, specifically in the ESR1 positive population. So going for the capivasertib and then going for the fulvestrant and then going for the SERD after that, I think that's a good therapy sequence. If we go first line CDK4/6, then we go PI3 kinase, and then we go for the SERD. Of course, the response times get smaller, but they also get smaller the other way around. And we have to see, therapy do we give the patients in the therapy lines, or they're still having like a quite good performance status. So even if I don't have any evidence, I think, for the therapy sequence and the respective performance status and the respective side effects, it kind of feels a little bit more manageable to go for, if there's a PI3 kinase mutation, to go for the capivasertib and then to go for the SERD if there's an ESR1 mutation. But any patient that shows up in my practice, a colleague does it the other way around. I'm not criticizing anything. I'm happy for any good therapy response because there is no evidence, there is no guideline in which order this should be done. And the question that you raised, Shaheenah, the complete suppression or the even better suppression of the estrogen pathway in combination with all of these other substances seems to give some additional efficacy for all those combination therapies that we've seen, let it be the mTOR inhibitor, let it be the CDK4/6 inhibitor. And of course, with the capivasertib, also data is generated in combination with the SERD. So let's see what comes out of that one.
So Ozge, I'm coming back to you. Your patient has both an ESR1 mutation as well as a PIK3CA mutation. What are you going to target first? Why are you going to target using that pathway? And what were the factors that went into your consideration for targeting that particular pathway?
I will target the ESR1 mutation pathway, and I will also target that one. I will target it with the capivasertib and within the combination treatment. So for a better response. And then what was it?
So you have a patient that has two mutations, ESR1
Yeah.
and PIK3CA. You are saying you're going to target the ESR1 first.
Yes.
Why?
See, as Dr. Peter Fasching said that in a good way, I think just as a summary, kind of like all the data is showing that when you like just prioritize the ESR1 mutation pathway with any combination, the data is more like favoring you. I mean, you can cover the other resistant pathways and such.
Okay. All right. Maha, what would you do?
To me, it should depend on the duration of CDK4/6 inhibitors. It can also depend on like the disease. Are we talking about a small volume of disease, very low progression, you know? But again, for me in my head, I think given all the recent data, combination works. If you can get access to combination therapy, for example, let's say the patient is on CDK for the last 3 years, and she's on, for example, palbociclib, then I would switch to SERD and Abibas. However, if a patient is on CDK4/6 for a year and she has dual mutation, I would go with like a SERD and capivasertib and do subset if I can get access and there is no limitation.
So are you
especially with
saying,
visceral disease.
so what I'm hearing is that you would use an oral SERD in those patients who have a long PFS and minimal burden of disease as single agent oral SERD. But if you had something with more progressive disease, rapidly progressing, you'd prefer using combination with CAPI plus an endocrine therapy agent like fulvestrant. Is that what I'm understanding?
Yeah, but I would also consider giving SERD and everolimus in some patients, for example, who don't fit the criteria for capivasertib or have contraindications.
All right. So, Dr. Tarkan, what would you target first, the ESR1 pathway or the PIK3CA pathway, considering you have dual mutation?
If we have fulvestrant and capivasertib, we are actually targeting both.
Okay. All right.
Yani,
So,
yeah,
but
we
what
are
would
targeting both.
what would be your
I will
preferred
go.
pathway?
I will go for this phosphoinositide 3 and plus fulvestrant is an option. Or as I told you before, the Elevate San Antonio poster showed me elacestrant plus Cabi is also a good and reached to 11 months PFS. That was also good.
Okay. All right. So you're just going to think totally outside the box and give CAPI plus LSS. I love that. I love that. Okay, let's
But
do some case studies.
Maha has to approve it.
Maha, go ahead and approve what Darkan wants to give if you want him to still be your friend. All right. So this is a 35-year-old lady. She's married. Presents with stage 4 de novo breast cancer. She's got liver mets, lung mets, bone mets. Biopsy was sent for profiling, and you can see this woman has an ESR1 mutation, a PIK3CA mutation, and it is HER2 negative. So I've just put like just a summary of her treatment over here, of her profiling. She was commenced on CDK4/6 inhibitor plus AI plus ovarian function suppression. Her PFS was 14 months. Liquid biopsy done, and you can see the liquid biopsy actually confirms the presence of that ESR1 mutation. And she had progressed in the liver and bone and is not in crisis. Sinem, I left you to the end because I was allowing Ozge and Ahmed and Maha and Tarkan to give us their thoughts. And then Peter also chipped in and said it doesn't matter what you start off with. So, Sinem, what are you going to give in the second line setting? This lady has a PIK3CA mutation and an ESR1 mutation.
Actually, this lady has co-mutation, but since there is no phase 3 trial yet, I'm not in favor of combination of ESR1 and capivasertib. So probably I will go with capivasertib fulvestrant. Why? Fulvestrant has also some ESR1 activity. And second thing, she has liver mets, yani tumor burden is high. So I would go with a more efficient treatment as my clinical experience.
Okay. So
Can I ask a question, Doctor, for this case, for the beta,
yes,
Dr. Shaheenah?
yes,
If
yes.
this case is 35 years old, carries the same time germline BRCA mutation, what's the opinion for Dr. Peter and you for sequencing of such a patient?
That's an excellent question. I will allow Peter first to answer, and then I will answer.
So-
Or you want me to
so-
answer first?
So now we're having a patient PI3 kinase, ESR1, and BRCA mutation.
Yeah, it's a fantastic question.
That's a very good question. I might want to go because of the good tolerability with the olaparib as a monotherapy. These days, and you know what I say now, I hope that you find it as important as I do. The patient management is so important these days. If we are planning, this phase of a life of a patient, the patient has to be aware of what's going on and what situation they're in, that we're changing therapies and that we're trying to make this disease as chronic as possible to extend quality of life as far as we can, and that we're going to sequence therapies one after the other, and to have a good quality of life as long as possible is of utmost importance. I don't care too much about having 6 months of PFS and then 3 months of PFS, and then maybe switching to an ADC and getting 14 months or maybe 18 months, as long as the patients understand that nobody should be frustrated when we try out a therapy and we have to change it. I think, most of the therapy sequences are okay and are a little bit more reflecting of what your personal preference is. But in this context, I might go for the olaparib as early as possible, because I personally made a very, very good experience as far as it goes for quality of life with those patients, and postpone the other treatment afterwards.
So I would also use olaparib here, but for a completely different reason. Of course, um, um, quality of life is obviously the most important thing, and olaparib is very, very well tolerated. But I also think that we have enough data to show us that these patients actually progress very quickly on their first-line therapy with a CDK4/6 inhibitor in the presence of a germline BRCA, because we know it doesn't work as well. And so I prefer targeting that pathway as early as possible. And I have to admit, and I don't know if Peter is going to kill me over here, I actually give olaparib with endocrine therapy. I don't give the olaparib on its own. It's just like the Olympia trial. And so I give both together, and I've had patients do super, super well for a long period of time. The only caveat is at the time of progression of disease, I would highly recommend that you rebiopsy these patients, because you will find a lot of the time these patients have converted from an ER positive disease to an ER negative disease. At least from the few patients that I've had the ER expression go right down. And they've been on olaparib like for a number of years, and then it goes right down. So at least that's my thinking. Peter, what are your thoughts here?
I would never harm a patient or you. So so I personally go with a study protocol. I don't like to change recipes too much, but if a patient shows up in that combination therapy, I found absolute peace with that situation. I mean, it's completely reasonable to assume that a combination therapy works. All new trials that are being conducted in that setting, trying to combine endocrine treatment with PARP inhibition. So I think it's completely fine. As far as it goes for approved therapy situations, we don't change the recipes too much, but you might be a little bit ahead in a positive way doing that.
Thank you. Thank you. I like his very, very diplomatic answer. So
But I
this
mean
is
it. I mean it. I mean it.
Thank you.
Yeah.
So, all right, this is the second case. This is a 55-year-old lady who has recurrent breast cancer. Tissue profiling is done. She receives first-line CDK4/6 inhibitor plus an endocrine therapy agent with an AI, and her PFS now is 15 months. Now, remember, this is recurrent. This is not de novo. If you remember, the one before was about 14 months. It was de novo. Here it is recurrent. And here, not only does she have an ESR1 mutation, she also has an AKT1 mutation. She also has HER2 low disease. So my question to you, Ozge, is what are you going to target here? We know you like to target the ESR1 mutation pathway, but what would you do in this case? Would you target
You're not
ESR1?
stopping me. I just realized I was talking out of my head. I'm saying I will target ESR1, then I'm saying I
Okay.
will use capivasertib. You're not stopping me. Today was a really hectic day, so at the end of the day, I'm not aware what I'm saying. I'm so sorry.
No, that's fine. That's fine. We're all
Then
friends over here, so it's
Then
fine.
I realize what I'm saying, I'm conflicting with myself.
So what
Okay,
would you do in this case? What would you do in this case?
Okay, this first line AI plus CDK inhibitor, it's a good PFS, more than 1 year. And it's not like no crisis, it's just bone and lung disease, good ECOG. There is ESR1 mutation, AKT mutation. I would go with the combination fulvestrant with Capiva.
Why not the ESR1 mutation pathway? Its PFS is 15 months. If you look at the subgroup analysis of the Emerald trial, this would be the perfect candidate to use a drug like elacestrant if it were available at your end.
Yes, but I mean, what she received in the first line is AI, and we know that fulvestrant it's kind of having like third activity. I think I can go for still fulvestrant Capiva.
Okay. Peter,
Can I
if
ask
I may
question
ask,
again?
yes, please go ahead, Ahmed. You are asking so
Don't
many
put
cool questions.
germline Braca now.
No. Also for the scenario of the case, this case is relapsed after adjuvant hormonal treatment, maybe CDK in the adjuvant setting. And as you know, that PIK3 is truncal mutation. So this development of ESR1 mutation after 15 months, is this convince us that the main driver is ESR1 mutation, and this disease is not driven by PIK3 mutation, because this PIK3 is present from the start, and the patient is responding well in the adjuvant and after that in the metastatic setting. So I think the priority.
But Ahmed, this is not PIK3CA. This is an AKT1.
AKT, yes, developed. Yes, this is another story. Yes,
AKT
sorry.
mutation is also mainly early seen, but again.
But maybe develop
Yeah.
in the development.
Mhm. Yeah.
So, Peter,
But it
I
is
want to
always
ask
a driver mutation. It is known as a
absolutely.
driver
So,
mutation.
Peter, I want to ask you two questions. Say, suppose this lady actually relapsed during her endocrine therapy. She's got this AKT1 mutation. Say, suppose she also has an ESR1 mutation for sure, but let us say that she relapsed during her endocrine therapy. And ideally, I would say the same criteria as Inavo, but she doesn't have a PIK3CA. She has an AKT alteration. Now, does this change your mind as to what you're going to target, an ESR1 versus AKT? And what would you have done in that first line setting?
Well, in the first line setting, obviously, to get 15 months with the CDK4/6 and the Ahmed never already shows that this was a good therapy decision. Also showing that we shouldn't think maybe too much about the first line therapy unless they're in the Inavo situation. However, here, this this E17K mutation, that's quite aggressive. That's quite pathway activating. So in that case, to come back what Dr. Tarkan said, with the fulvestrant, I think there is a good coverage of the estrogen signaling pathway in a better way than the aromatase inhibitor. So we might be covering the ESR1 mutation to some extent with the fulvestrant, but with this ACT1 mutation, which is quite well known to be quite activating for the pathway, I want to shut down this pathway and see what happens. That's what I would just try out, to see in this patient second line with a capivasertib and shut it down.
And my second question, Peter, is does the number of ESR1 mutations drive your decision making when you have dual mutations? So say suppose this patient had 2 or 3 ESR1 mutations, and then you have the AKT mutation. Does that help sort of say, okay, it's better not to target the ESR1 because of what we saw in the subgroup analysis of Shaheenah? You think because oral SERDs may not work as well when you have multiple ESR1 mutation. Does that drive your decision making in any way?
Well, I think the mechanism behind it is not well understood. I mean, does it not make sense to target it because the binding or the mechanism of action of the SERD is not so efficient degrading the ESR1, or is there like a more like a quicker escape mechanism or a quicker transcription mechanism active, where you still need a SERD in order to get some efficacy in the estrogen receptor pathway. So I'm not that much driven yet by that data. I want to learn a little bit more about what's to be done. But if there is a PI3 kinase mutation, AKT kinase mutation that's signal pathway activating, I want to shut down this first with a fulvestrant and then go for the ES1, regardless of the number of ES1 mutations.
So this is a 30-year-old lady. She's got a stage 3 breast cancer. She's treated with everything, including chemo, radiation, surgery, and she's put on adjuvant tamoxifen. She stopped tamoxifen after 2 years because she wanted to have a baby. And then post-delivery, she restarted tamoxifen. And unfortunately, a year after that, her disease came back with a vengeance and she had extensive bone mets. I saw this lady for the first time actually limping into my office because she was treated in a different country and then she came to the UAE. She was limping into my office. I did a PET CT and her PET CT basically lit up like a Christmas tree. We biopsied her bone met and it confirmed that it was an ERPR positive, HER2 negative disease. And we sent her tissue for profiling. Now, this lady has a PIK3CA mutation. This is just for you, Dr. Ahmed. I'm going to ask you the question because you've just been asking us all questions. So I'm going to ask you the question. This patient's tissue profiling showed a PIK3CA mutation and a germline BRCA mutation. What are you going to do? How are you going to target this patient in terms of therapy?
I need to know how long did she stopped tamoxifen for pregnancy?
So she
For how
stopped.
long?
So she took tamoxifen for 2 years, and then she stopped tamoxifen for a year and a half because she got pregnant, she delivered, and then she didn't breastfeed. She went back on the tamoxifen then. So she was off her tamoxifen for a year and a half. Then she took tamoxifen for 1 year, and unfortunately, at the end of that year, that's when I think she had bone meds before that, but she just came limping into my clinic. That was the first time I'd seen her.
I think it is like aggressive disease, but bone-only disease. So I will
Bone only,
keep
but
on.
if you see this PET scan, like the whole PET scan lit up, her organs were preserved, but it was like a Christmas tree. Honestly, it was like
I mean that I will be in this setting will be adherent to endocrine therapy also again before PARP inhibitor for my practice. Maybe INAVO protocol may be option for this female as a criteria of INAVO trial. Then after that, may I think for PARP inhibitor.
Dr. Tarkan, what would you do here?
Yani, I have to have a good response. Yeah, okay, it is bone metastatic disease, but again, extensive disease. It is not a hormone, refractory disease, but again, it sounds like refractory and has phosphoinositide 3 kinase mutation. I have to target phosphoinositide 3 kinase mutation. I will go as either INAVO or fulvestrant capivasertib, this plan, and leave. But CDK4 I have to use also. I want to use also. INAVO looks good.
So this woman
Does it fit the criteria of INAVO?
She actually does fit the criteria of INAVO because she relapsed while taking endocrine therapy. But she had that break to have her baby. Yeah, absolutely.
But INAVO, yeah.
So, Peter, I want to ask you a question with regards to INAVO. In terms of, we know there's an overall survival advantage. Nobody's questioning that you need to use INAVO in patients that fit the criteria for INAVO. Nobody's questioning that. But you had a good proportion of those patients who had only ever received tamoxifen. Would it not, I mean, is it unreasonable to give a CDK4/6 inhibitor plus an AI in those patients who've relapsed and then go on to Capi plus fulvestrant, doing that sequence rather than doing INAVO upfront? Because I don't think that trial actually answered that question for the tamoxifen alone group.
You were joking. Nobody's questioning that because you know that I questioned that on a regular basis. So it's
thank you for supporting my question, Peter. Thank you. I thought I was the lone ranger. I repeatedly asked this question, and everyone thought I was crazy.
I mean, we've seen the data, in Monarch 3 and Mona Lisa 3, Mona Lisa 2. There's a small fraction. They've all been genotyped, and the overall survival data of these patients in the first line that match those criteria doesn't look as bad. It looks actually very similar to the overall survival in the INAVO study. So now the question is, and it's a pure hypothesis, it's a question. I'm not suggesting anything, and I don't want to imply anything. Do we want to give the less efficacious CDK4/6 inhibitor, as far as it goes for overall survival, to add a PI3 kinase inhibitor to get similar overall survival data as in Mona Lisa 2 or Mona Lisa 3? So I think for this patient, approach it from a positive point of view is she most probably with the BRCA mutation already has some kind of endocrine resistance. But she has so many options, as far as it goes for therapy sequencing. I would start her on a CDK4/6 inhibitor and aromatase inhibitor and a GnRH analog. And then after that, I might want to put her on the capivasertib or the olaparib, and then after that, the other one. So she has 3 therapy lines, that are not very quality of life impacting, that she can do one after the other and most probably don't make many mistakes. I personally would start her on a CDK4/6 inhibitor and then most probably give her capivasertib depending on the response time in the first line setting, and then put her on the olaparib. And then she has 3 therapy lines. Hopefully we can give her 2 years or 3 years or even longer on progression-free survival time. That would be very good. But it's always very heartbreaking, these young patients. It's just a baby. We want to do so much, but if she's really metastasized, we shouldn't let emotions take over and just try to maintain quality of life as long as we can.
So, Peter, I also want to ask another question with regards to the INAVO trial. We now give endocrine therapy for 10 years in a lot of these high-risk patients, rather than just giving only 5 years. Is a patient who recurs within 2 years of starting endocrine therapy the same as a patient who relapses, say, at 9 years of endocrine therapy and has a PIK3CA mutation, in terms of thinking about using INAVO versus the sequencing strategy?
Yeah. They have a quite different prognosis. I mean, patients who relapse early have a much worse prognosis compared to patients who relapse late. So I want to believe that molecularly there's a large difference. A good question would be, where I don't have an answer, is there a difference between a patient who relapses 2 years after the beginning of endocrine treatment, under the endocrine treatment, versus 4 years under the endocrine treatment? I don't think there's such a big difference between these 2 patients. But if a patient has an early relapse versus very late relapse, even under endocrine treatment, there's a quite different prognostic pattern in these tumors. So they are very different, in my opinion.
All right, so I'm going to just do the last case very, very quickly because we have 3 minutes. This is a 45-year-old lady, stage 2 breast cancer, received everything. She was on tamoxifen. She completed 5 years. Her disease-free survival now is 7 years. So she relapsed 2 years after completing her endocrine therapy. She's got extensive liver metastases. She's given a CDK4/6 plus an AI plus ovarian function suppression. PFS is 9 months. She has progression in her liver. She is not in crisis, but she has significant disease in the liver, but she's not in crisis. Liquid biopsy is done. She does have a PIK3CA mutation, but she also has HER2 low disease. Maha, what would you do in this patient?
I would go for capivasertib and fulvestrant, and then I would leave the chemotherapy for later.
Okay, Dr. Sinem, what are your thoughts over here?
Me same, because TDXT is not so also a very tolerable drug, and I want to start with the capivasertib plus fulvestrant, and I will try to start chemotherapy as soon as possible. I want to delay it.
So, Peter, when is it that you do DB06 when you have a choice between targeting the PIK3CA pathway versus, TDXD?
A clear answer: endocrine treatment as long as possible, and then give the ADC later on. It's an easy question for me.
So I have a patient right now with extensive disease. I gave her a CDK4/6 inhibitor, and she was actually in crisis, but I gave her Peter's favorite drug, ribociclib plus endocrine therapy, and I actually took her out of crisis. She did actually very, very well, but her PFS was 7 months, literally. And she started to progress again, and she's progressing rather quickly. She's got a PIK3CA mutation. She's got mild ascites. Now, at this point in time, and she's got HER2 low disease, Dr. Tarkan, we are at the top of the hour. Peter is going to run away in a minute. I need you to tell me very quickly, what are you going to do? TDXD or Peter's favorite combo, Cappy plus fulvestrant in this particular patient, because I need help as to what I'm going to do tomorrow in the clinic.
So anyhow, both drugs are in the same company. I don't think it will make so much difference for them. As Peter said, hormone, I will try hormone, but I will have a doubt 6 months
7
to
months,
have a
actually.
response.
It was 7
Yeah,
months.
7 months. Yeah.
Well,
Personally,
will
I'm
choose-
feeling uneasy giving her Cappy plus
Treatment.
fulvestrant simply because she's begun to have ascites, and I'm just not
Yeah.
liking the overall look.
I will
But
go also.
Shaheenah, the question
good,
is
because
easy.
you're my friend. What are you going
Yeah.
to do, Peter? Remember, you need to
The-
stay my
the-
friend. What are you going to
the-
do tomorrow?
The question is easy. It's absolutely your call as the doctor. When she progresses under the next endocrine treatment, will she still be fit to get the
I don't think she
TDXD?
will be. I don't
Then
think
you,
she will be.
then you have to give it now. Then you have to give it now.
Yeah, yeah,
There's your
yeah.
answer. There's your answer.
Maha, what would you do?
I agree. It will depend on patient symptom and burden of disease. Like if you think you're losing the patient, then definitely chemotherapy is the safest option. And you can always later on, once you
Go
get them, go back to endocrine therapy.
Okay, so I've used 1 more minute. So thank you all very much. I've thoroughly enjoyed myself. Dr. Ozge, I hope you get a good night's sleep. You do look very tired after the long day. Tarkan, you're still my friend. Ahmed, you asked fantastic questions. Sinem, you are totally cool. Maha, I think you're at a dance party somewhere. Please take me with you. I like Latin dancing. And Peter, please continue to miss me because we have to be together at the next EIOC Journal Club. So thank you all. I
Thank
thoroughly
you.
enjoyed myself. Have a good night.
Thank
Take
you.
care.
Thank you.
Bye.
Thank you.
you.
Bye-bye.
Bye.
Bye-bye.
Bye. Bye.